Hello, everyone. Welcome to Cracking Addiction. My name's Dr. Ferghal Armstrong, and we have with us Dr. Richard Bradlow. So, further to our chat the last time, I think we need to talk about the specifics of opioid risk management. So, why do we need to manage the risk of opioids before we then get on to the absolute techniques?
Yeah, well, I think when I think about risks in general, I think about short-term and long-term risks, right? And I think the short-term risks in opioids is overdose, which is obviously
Yeah,
terrifying. And in terms of accidental drug overdose deaths in Australia, opioids are absolutely right at the top, um,
yeah, they are. They are.
by a country mile, actually. Um, why? And then I think longer term risks. Well, I think about things like opioid hyperalgesia, um, addiction,
Yeah.
dependence. Yeah.
So, what can we do as prescribers to mitigate the risk of opioid toxicity in all its forms?
Yeah, well, I think it starts with assessing the patient, making sure the reason you're prescribing opioids is the right reason.
Yeah,
When if you have made the decision to prescribe opioids, I think prescribing any drug I'm prescribing, I'm thinking about when I'm going to stop prescribing that medication. Doesn't matter if it's
yeah,
opioids, doesn't matter if it's a medication I never plan on stopping prescribing. I still have that in my mind about my exit strategy, and perhaps my exit strategy is no, this is a lifelong medication, but for opioids, it obviously shouldn't be. And I think it's
hmm
about having honest conversations with the patient from the get go about the risks and benefits of the medication, having them providing that on paper as well as in person and documenting the exact conversations you've discussed. Um, Once I have prescribed the opioids for the right reason, had shared decision making with the patient, and been very clear about where I'm going to end it, I then make sure I'm doing frequent checkups and I've discussed if it is a very high dose of opioids, which in my profession as an addiction specialist, I am often prescribing high doses of opioids to help people come off them. I'm having conversations about harm minimization strategies, how to do this safely, how to make sure that you're not going to have an overdose.
yeah, yeah. You're absolutely right. You know, the consideration of opioid safety starts with the initial assessment. I mean, to that, I would actually add that you need to have clearly defined functional goals if you're going to prescribe an opioid. Secondly, if you're dealing with chronic non-cancer pain, which most of us will deal with, you need to try and keep the OMED low. You need to certainly keep it less than 60 milligrams, which is the upper limit of what the ANSCA guidelines would recommend. And thirdly, you shouldn't be using long-acting opioids in people who are not opioid tolerant, because effectively all they do is just increase risk without any payback in terms of clinical benefit.
I have a question
But
just on
go
that
on.
Fergal. Let's say I'm doing an
Yeah.
opioid wean on someone with a history of chronic pain that's got
Yeah.
themselves into
Well,
a
that's
trip.
different. Yeah.
Yeah.
Yeah, that's different. So when the situation of the inherited patient, very often you find that they're already on long-acting opioids, because there is a vogue to say, all right, if someone's requiring high doses of opioids, and it's all about opioid stewardship rather than actually the primary goal of improved function. Now, you tend to find they're all on long-acting opioids, usually twice daily dosing. Um, in that situation, then you are going to have to continue to prescribe long-acting opioids as you are weaning them down. But when I say don't give a patient who's opioid naive long-acting opioids for acute pain,
Sure.
there's a specific difference in that cohort. The
In
question
that
then becomes
situation,
if we're
Fergal,
managing. Yeah,
sorry, in that situation where you've inherited a patient on long acting opioids, they might say to you, um, look, I'm on 40 milligrams of oxycodone a day, 220s, right? I'm happy to
yeah,
wean, but I would like to go into a mixture of short and long acting. Do you have a problem with that?
no. So long as the overall OMED is slowly going
Yeah.
down, doesn't
No,
really
me as
matter.
well. I agree. But I think there's a feeling amongst a lot of practitioners that if we're going to do that wean in a similar way we would do it with benzos, we should actually be limiting them to the long-acting.
So I actually prefer short-acting opioids during opioid weans. And this may not be a view that's held by everyone, but let's say if I'm coming off, I don't know, 40 of Targin a day, right? That's the equivalent of 2 tablets of Targin, one twice a day, right? The equivalent of that in endone would be 8 tablets of endone. I think it's an automatic signal of just how much opioids you're on if you're having to take 8 tablets a day. And it gives patients, milestone waypoints as they're reducing, 8, 7, 6, 5, 4, 3, 2, 1, stop. So that's why I like weaning people off a combination or short-acting opioids. But there are those that will say, well, the perceived wisdom of an opioid wean depends on converting all of the short-acting to long-acting opioids and then gradually reducing the long-acting opioids in the background. The other problem I have with that is that if you convert all of the short-acting to long-acting, you got no room to play with in the event of an acute pain crisis. Whereas at least if you have some short-acting opioids and you have a quick win by reducing the OMED, then you've still got short-acting opioids to play with.
Yeah. What other options do you have when you're weaning?
Well, I think the key thing is to understand that it's not a race. That's option one. You have the option of a holiday. So you can pause for a couple of months. I'd never go up, but it's certainly reasonable, especially in the winter. People are saying, oh, look, the cold makes my pain worse and I'm more stiff in the mornings in the cold. I've got no problem with people having a holiday. And the other thing is that if you're overzealous in your opioid wean, you tend to risk patients' mental state deteriorating. I mean, this overzealous weaning has been associated with increased risks of overdose, increased risks of deterioration in mental state, and also increased risk of suicidal ideation and thoughts. So, in fact, the CDC, further to its initial recommendations about very strict opioid weans, has kind of emphasized the point that opioid weans are not indicated for anything other than high dose opioids in the context of chronic non-cancer pain. I'm also mindful of the fact that originally when I started doing weans, I would quote figures of like 10% a fortnight. I think that's way too high. 10% a month is probably the most I would wean these days. And there's some literature to support that very slow wean.
I often actually have to find myself in the room with the patient counselling a slower wean than they want to push because I don't want to set them up for failure. And I think you often
exactly.
you get a patient in the room and they've had a doctor that was previously prescribing a lot and they have a strong, they don't want to be associated with having opioid use disorder and they so badly want to prove it to you in the room that they'll say, oh, well, I can get down and say, oh, hang on. Like, I don't want that to happen and you to overdose in a few weeks. Let's do this a much more calm manner. I won't say though, I might be a bit more robust than you in terms of the holidays. I do have in a particular difficult month, I will say, okay, but it will go down next month and I won't fight too hard. But I never put that on the table, if that makes sense.
What do you mean by you never put it on the table?
As in, I would never, if we're having a review and I say, well, we're going down this month and the patient says, no, I really can't. I might say, okay, well, then we could do it next month or let's go down by just a tiny bit, like let's say half an endone a day or however we're doing, maybe, like over the week we'll drop one, a really tiny amount. So we're still marching for progress. But I never sort of say, okay, we'll have a holiday for a couple of months over winter. I think that's sending the wrong message. I think we always need to be marching. Doesn't matter how slowly we walk, as long as we're walking.
Yeah, that's a good point. Yeah. We should be marching. I have to say I don't volunteer the over the winter holiday. It's something that I negotiate too. Yeah, I'm always trying to say, look, just doesn't matter how slow you go, but as long as you keep going.
Yeah,
It's
I mean
not a
that must be
race.
why your outpatients are always so much more busier than mine, Ferghal, because you're known to be old pushover Armstrong.
Push over Armstrong. Oh
What
dear,
about
I hope those words don't haunt me.
what about when do you ever do stuff to help around the dose drop? So when we are going to do a dose drop, say we're dropping once a month, do you ever help out in other ways?
Yeah, so there's a very useful way of actually jumping quite precipitously without the patient actually realizing what's going on. And that is with an opioid rotation. So, an opioid rotation works basically on the principle that there's no complete cross tolerance between one opioid and another opioid. So, if you stop the first opioid and you go on to the equivalent amount of the second opioid, because there's no cross tolerance, you're actually probably going to cause an overdose just by jumping to the equivalent amount of the second opioid. So, as a matter of safety, you actually have to reduce the dose of the second opioid by half. So, by this way, by this reduction of the second dose, the dose of the second opioid by half, you're actually reducing the overall load of opioids on the patient, and they don't feel any different. They still feel that they're still controlled in terms of their pain. And this process is called an opioid reduction. So it's really important when we're thinking about an opioid reduction to think about OMEDs, the oral morphine equivalent dose. So let's for instance, an OMED of 100 milligrams of morphine by definition is OMED of 100 because everything's compared to morphine. So if someone was on 100 milligrams of morphine a day, you wanted to rotate them to the equianalgesic dose of endone, that would be roughly 60 milligrams of endone a day, right? That's roughly the same. And we know that because of OMED calculators. But if I transferred you from 100 milligrams of morphine to 60 milligrams of endone, you would quite likely get opioid toxicity because you're not used to the endone. There isn't this complete cross tolerance.
Mm,
So therefore, to keep you safe, you probably need to reduce the endone to maybe 30 or 40 milligrams.
mm,
But say 30 milligrams of endone is actually only 60 milligrams, or sorry, 45 milligrams of morphine. All right.
mm.
So you've jumped from 100 milligrams of morphine to less than 50 milligrams of morphine in one opioid rotation, and you've maintained the potency of the opioid analgesia. So that's an opioid rotation, and that can be done in a wide variety of clinical settings. It can be done in an outpatient by any GP. But the key thing to remember if you're switching from one opioid to another opioid, do not give the equianalgesic dose of the second opioid. Otherwise, you'll risk toxicity.
What's the how frequently can you do opioid rotations?
Every week. So you could literally rotate week and you could go back and forth. As soon as you get used to the dose of one opioid, which is usually about a week, I reckon, then you can switch again if you have to. So theoretically, you could within the space, if you were just reducing by 25% rather than 50%, theoretically within 4 to 6 weeks, you could be awful, or down to
Mm,
minuscule amounts of opioids.
mm.
Not that we would do that in clinical practice, but it is a theoretical possibility.
What about let's say we're dropping once a month? Would you ever give a bit of clonidine or diazepam around that time?
I probably wouldn't give diazepam because if we're talking about opioid uh, deprescribing and we're talking about a gradual decrease in opioids, remember for a large part of that time, we're still dealing with someone who's on, relatively speaking, very high amounts of opioids.
Mm,
And so we know that there's a relationship between the toxicity associated with opioids and the toxicity associated with benzodiazepines.
mm,
So opioids will knock off hypercarbic respiratory drive, the drive
mm,
associated with carbon dioxide retention, whereas benzodiazepines will knock off hypoxic drive, i.e., the drive associated with the lack of oxygen. So if you combine both opioids and benzodiazepines together, you can really quickly knock off completely the respiratory drive, which, as we know, can cause significant problems. So I wouldn't tend to give diazepam to facilitate a gradual opioid wean. But clonidine wouldn't be amiss. I've actually used clonidine to help people gradually reduce off fentanyl patches. I inherited a patient on 100 of fentanyl a day for rheumatoid arthritis that had been burnt out. She was in her 60s or 70s, and she didn't have any active disease, and
Mm.
she wanted to get off the fentanyl. And I just gradually reduced the fentanyl patches. She saw me every 2 weeks, and we agreed a drop date. And for the 3 days after the drop, she had clonidine, and it worked a treat. So yeah, I would support the use of clonidine during a taper.
I
How does clonidine work, Richard?
How does clonidine work? Clonidine is an alpha 2 agonist, meaning that it so alpha 1 antagonism results in, it's a downstream effect, and it's essentially resulting in less norepinephrine or noradrenaline release. Alpha 2 antagonism has the opposite effect. It has a stimulatory effect. And the medication that is an alpha 2 antagonist,
Yohimbine.
yohimbine. I was thinking metazapine, but yohimbine. I've never heard of yohimbine. And then clonidine.
Two antagonist. So clonidine, to be specific, clonidine is an alpha 2 agonist.
Yes, clonidine is an alpha 2 agonist, as is guanfacine.
Dexmedetomidine.
I mean, I don't. You could be making up this yohimbine and
I could be making up
sure.
polysyllabic, paraphasic, meaningless gibberish.
But I mean, the ones that I use in my clinical practice, I know. Metazapine is also an alpha 2 antagonist. That's where it gets its excitatory effects at higher doses. That's weird.
So, what was the other drug that you were going to say was an alpha 2 antagonist?
I said that clonidine and guanfacine are alpha 2 agonists.
Yeah. Guanfacine. Yeah. So yes, that's marketed as Intuniv, and it's licensed for pediatric ADHD.
Mm-hmm.
Yeah. So we've talked about.
But I think that's. By the way, I think that's slightly robust. I do prescribe a little bit of diazepam when the dropping. I understand that the theoretical risk is there, but I think 4 tablets of diazepam buys a lot of. I think what we're doing with the clonidine and the diazepam more than is we're demonstrating to the patient that we care, and we're demonstrating that we're still trying to act in their best wishes, and we're trying to meet them halfway. Yeah. That's what I'm doing. I think that 4 tablets of diazepam makes a meaningful difference? No. Do I have conversations about risk of overdose and don't take them all at once? Yes. But I think it's about demonstrating that you are seeing their difficulties and working with them.
So before we wrap up, you can't have a conversation on opioid safety and stewardship without talking about the antidote to opioid toxicity. Tell us about that.
Well, there's lots of opioid antagonists, not just naloxone, which is a short-acting medication that's not absorbed orally, which means that it is the one that we use in either a Nixoid spray or an IM injection or an IV injection if you're in an ED or an ambulance. And what it does is it's an opioid antagonist, and it's got quite high affinity. So essentially, it's sitting in that downstream receptor. It's kicking off whatever exogenous opioids you have in there, and hey presto, the respiratory depression from the opioid agonist they're on stops. But of course, there's naltrexone. There's nalmefene, which you can't get in Australia. That's more of a partial agonist. And there's buprenorphine, right?
Yeah, but you wouldn't. I don't think I would treat an opioid overdose with Suboxone, buprenorphine.
No, I wouldn't, but I'm sure it would work.
I don't ever recommend that. But just I want to make the point that actually Nixoid spray should be prescribed to anyone who's at risk of opioid toxicity. That's not just people who are suffering from heroin use disorder. That includes little old grandmothers who are on 2 endones a day, because they too are at risk of opioid toxicity. And it's very convenient.
In a young, healthy person, what's your OMED that you would prescribe the Nixoid spray for?
I used to say 50, but now I say anyone who's at risk of opioid toxicity gets a Nixoid. And so I always ask the question, why not, rather than why. So more often than not, I will prescribe the Nixoid to everyone. There was a recent study, an analysis of a pilot study done by the University of Queensland that demonstrated if you gave Nixoid to everyone, it saved 3 lives a day, which I think is pretty good Australian evidence for the benefit of Nixoid spray, naloxone nasal spray. And I think it should be made widely available as part of opioid safety and stewardship.
Yeah, I think that's a fantastic idea. And often the person you're prescribing it to is not the person who's going to have their lives saved by it, but they're going to save a life. So that's why my boss
Potentially.
at my public job has Nixoid spray in her handbag at all times because she works around addiction and is often finds herself in areas where there are people that use drugs, and she thinks to herself, well, one day I could save a life from it. Terrific. You can get it in Australia now without a prescription for free from a chemist.
So on that sweet note, we're going to have to wrap it up, but thank you for today and your pearls of wisdom. Thank you.
Thank you for having me.
That's all for today, folks. My name is Dr. Ferghal Armstrong, and this has been Cracking Addiction.